lingering cough. And remember we said the symptoms for lung cancer are somewhat vague, all right? So this could be anybody. Goes to the doctor, has had a cough that won't go away, trying to figure out what's going on. He's young, he's only 51, okay? No history of smoking, but for the past 6 months, he's had this cough that's not going away. The doctor listens to chest sounds, they sound okay, he's not wheezing, which kind of makes you think he doesn't have bronchitis or any kind of maybe chronic obstructive pulmonary disease, anything that would interfere with breathing that way. So the physician orders a chest x-ray, which is typical, okay? And what they saw was something that appeared to be a mass. And so I circled it in red here. This is right out of your book. You can see the lungs here, okay? And you can actually see something that's in the lung that looks abnormal, okay? So it looks like there's something in there that's more dense than the actual lung tissue, which is actually quite open because it's alveoli and it's full of air, okay, which is going to appear black. But you can see that there's something more dense there, okay. So this is suspicious. And so the first question was, we have to figure out what this is, all right? So what other tests would be appropriate to figure out if this was a cancerous or a non-cancerous nodule or lesion, okay? So what did you think could be done to help figure out if this thing was maybe just some inflammation or something, or if it was actually cancer?
Biopsy?
Yeah, exactly. Well, you could do a few things. You could do more imaging, okay? X-rays are okay. They don't give you a lot of detail though. You could do PET CT or MRI, all right? Especially a combined PET CT. That's a little expensive though. So more often than not, this might be done, and what would definitely be done is to do a diagnostic biopsy, followed by histological evaluation. So the doctor would go in there, probably a pulmonologist, would go in, get a piece of tissue. We talked about the ways that could be done percutaneously or through the bronchoscopy method. And then that would go to pathology, and the pathologist would look at it and determine whether or not those cells look normal or if they look like cancer, okay? And so what else might be done to help figure out if any of the surrounding or draining lymph nodes were cancerous, or if there were actually more distant metastases outside the lung.
We talked about the CT PET fusion scan.
Yeah, that's a good one. So that will actually show you whether there's not areas of metabolic activity, okay, that could be associated with the lung cancer. So a PET CT would help you figure out if in fact any of the lymph nodes nearby were cancerous, and actually might actually, depending upon where the CT scan is done, or where the, let me put it this way, depending upon the extent of the scan, could actually tell you if there were distant metastases, for example, in the lung or the brain. Unfortunately, lung cancer likes to metastasize to the brain, so that would be a place to look. Okay, so what did they find? So they did the biopsy, okay, of the lung mass and the surrounding lymph nodes, and showed that they were cancerous. So there was a primary mass, and then some of the suspicious looking lymph nodes actually held cancer cells as well. And pathology, again, based on the appearance of the cancer cells, showed that they were non-small cell lung cancer, and actually that they were of the adenocarcinoma type, okay? So remember, for non-small cell, there were like 4 different subtypes, and adenocarcinoma was one of them. Okay. So based on all this information, I asked you to go to table 4.5 in the lecture and determine the tumor stage and explain your assessment. So table 4.5 in the book, but I also gave it to you in the lecture, okay? Let me see if I can find it here.
Oh, is the floor open, Professor, or do you want us to wait till we talk about the staging?
Oh, it's open. I was just looking for the table, but go right ahead. Go right
So
ahead.
I was thinking stage 4 because
Hmm.
in the case study book they said there was also a growth. They later called it a lesion in the liver. I don't know
Yes.
if I was reaching when I said that though.
Well, let's look at what it is. Okay. So you are right. Okay. It is stage 4, and that's actually not. It's because tumors of any size with any lymph node involvement, which is what we know so far, and spread to distant organs like the liver. Okay.
Copy. I put lymph nodes as well in my answer. Okay. I
Yeah.
forgot to say it though. That's my bad.
No, it's okay. So actually, that's fine because we're looking at if you have a tumor with any lymph node involvement, that's going to up the stage. Okay, and unfortunately, what that means, as we talked about with the AJCC staging, the higher the AJCC staging, unfortunately, the worse the prognosis. Okay, because these are larger tumors or more disseminated, meaning they have spread outside of the primary site. Okay.
Professor,
Mm-hmm.
I'm looking at the table right now.
Oh, I just closed it. Okay.
For stage 2, it says tumors up to 7 centimeters with involvement of nearby lymph nodes.
Mhm.
That's what I thought was being described here.
I think that, let's see, let me see if I can find him. Did they say, oh, here it is. Okay. So the thing is, what I didn't put here, but it's in the case studies book, is that he had a large tumor. So his tumor was a 5 by 3 by 3 centimeter lung mass. That's pretty big. You can actually see it on the x-ray how big it is. So you have to take into account that he had a large mass, he had several involved lymph nodes, and a small liver mass. So that's all in the book.
I thought we were only going on the information provided in the worksheet here.
No. I said you need to use, no, you need to use the case studies book because I'm not going to copy and paste all the information from the book onto the worksheet. So you have to read through the case study. I'm giving you bare bones.
I was confused about that too, because on the worksheet, it doesn't mention that you have to use the book. I didn't purchase the book because I
It
did not
certainly
think
does.
that it was
Excuse
necessary for the
me.
worksheet.
It says use information in lecture 8 and chapter 4 of the case studies book. You have to use the book. And I said that many times already. You have to use the book. I can't just replicate everything from the book into these worksheets. So there's much more in the book than I'm able to put here. Okay? So you absolutely do
I assumed
have
that the
to
information
use
at
the
the
book.
top of the worksheet was all the information we needed for.
No, that's not what this says.
Okay.
This just
All right,
is
I was
the
correct.
introduction to it. Okay? So now you know, all right? And now you will know when you go forward in the other worksheets that if the information is in this book, you need to use it. Okay, so let's just go on. All right, now that I know there was a misunderstanding, I'll take that into account, but not going forward, okay, because now you know. All right, okay. We did that. Okay, so what would be the standard treatment for Alex's type and stage of lung cancer? We had this in the lecture, and then in the case studies book, they also mentioned a couple of things. There is not one answer to this. So you had some choices, and they would all be correct. It would always be a combination chemotherapy for this, okay? And so we mentioned cisplatin and pemetrexed, cisplatin and gemcitabine, and the book actually says carboplatin and paclitaxel. These are all okay, all right? So just depending upon the physician's choice, actually, any of these would be acceptable, okay?
I have a question.
Mhm.
What would be the standard treatment for another stage, another type and stage of lung cancer for another patient?
So if this were localized, they were talking about using that EP, which is etoposide, I think in pemetrexed. But for more advanced cancers, you actually have to get into the more genotoxic type
Okay.
combo chemotherapies. And so you're going to always see a cisplatin, of some time, or a platinum drug, cisplatin or carboplatin. And then that'll be paired up with another chemotherapy, depending upon things that we don't all have here or in the book, that the physician would know about the tumor and about the patient, to be able to figure out the initial combination therapy. Because remember that sometimes, actually a lot of times, patients with advanced cancer may go on one kind of therapy and they may respond to that for a while, but then they will start to progress. And if that happens, then they would go on to a second type of combo care therapy, and then maybe a third. So there could be sequential rounds. And that explains a bit why this initial choice could be any of these. And then if the patient starts to fail, they would be put on the next combo. Okay.
Okay.
Professor, I just had a quick question as well. In the case of Alex Washington, we have the primary tumor, which is locally advanced,
Yeah.
and then we have that lesion in the liver, and then of course the lymph nodes surrounding the tumor or in the lung area. So, I mean, at what point do the team of doctors then say, hey, should we consider surgery if it's only advanced in this area and there's only a lesion in the liver? Is that something they would consider after multiple failures with combination chemotherapy?
Usually
Even if it's
not.
stage-
So usually surgery is really only for localized disease.
Okay.
Once there's metastases, excising the primary tumor doesn't do a whole lot of good, So typically surgery is going to be for less severe disease.
Okay, got it. Thank you.
Yes, and actually I just mentioned this, that unfortunately for Alex, he responded initially, but then the tumor became resistant and he suffered disease progression. Okay, and so based on that and the type of non-small cell lung tumor Alex had, okay, what other treatment options might be pursued, and what other information would this oncologist need to decide what would be the next step for this patient. And by type, it's adenocarcinoma. So that should jog your brain a little bit to talk about a type of therapy that's actually very specific for adenocarcinoma.
So drug-targeted therapy to the fusion gene EML4.
Yes, yes. So what they could do is they could actually look to see if Alex's adenocarcinoma carried the EML4 ALK fusion gene. Okay, a small proportion do. It's less than 10%. But if in fact the tumor is showing this fusion gene, there is a targeted therapy, crizotinib, that could be prescribed for Alex. And so that would really be the only next step for this patient. Okay. So could Alex reasonably expect long-term survival from his disease here?
So the answer I put was kind of twofold. Initially, it would have been no, because it was stage 4 and it was metastasized. But after realizing that it could be targeted, and because there was resolution according to the clinical trials book, we can now not assume, but imply that long-term survival is favorable, because he's spent a few years of trouble-free life already after the crizotinib treatment.
So I think it depends on how you define long-term. So there would be an advantage to him, for him, to be on this drug, on crizotinib. Okay, his cancer is not curable. So unfortunately, it may actually, crizotinib might help stabilize his disease. So he might have several more years of life, but eventually he will die of metastatic lung cancer. And that's unfortunate at this point. That's hopefully that will change as new therapeutics come online. So this is not a curative approach, but it certainly could extend his life. Okay.
I have a question then. They had mentioned in the book that he had already been living 4 years like after prognosis, and like his disease has been stable. So you wouldn't have considered, and then I mean, I looked up the term long-term survival, and it said basically just living more than 3 years from your prognosis. So then I thought, oh yeah, it would be, even though it's not curable, but he's been living stable 4 years, which is way past the time of what they had gave him a prognosis of just over a year.
Yeah. So typically when we're talking about long-term survival, we're talking about that 5-year survival rate. So if he typically, if someone is considered cured from cancer, it means that they have not shown any relapse 5 years past diagnosis. Okay, so he doesn't quite make it. So it's the 5-year survival rate that we use to define long-term survival. And I agree that's a high bar, especially for someone who has bad disease like this. So Alex probably would have a different view of what long-term survival is than his oncologist. Okay, the oncologist is not going to say he will experience long-term survival from this approach, but for Alex, who has the disease, he probably thinks otherwise. So just for your own information, I would take either answer for this, depending on how you explain it, because you always have to explain it. But an oncologist is going to be looking at 5-year survival. All right, that's just the metric.
Yeah, I mean, my misstep was that I compared it relative to the initial prognosis. So, and then I made sure I didn't say remission, right? Because resolution, and this is something I wanted to ask you about, Professor. Resolution is not the same as remission, right?
No,
Those are two different terms.
resolution is cure.
Right.
So when we say the cancer has resolved, we mean it's cured, meaning it's gone. The patient has not shown cancer for 5 years, and that's considered a cure. Anytime within that, though, if they relapse within that 5 years, their cancer is not in remission. It's actually progressing. Right?
The book is a little confusing then, because the book shows the thing, and they say that the cancer had been resolved.
Yeah, it's not been resolved. Okay. Yeah, because he does progress. You know, he will not be cured of his disease.
That was a tough judgment call, though, because I mean, I was going based upon all the information I had, even in the clinical trials book, and it was a little misleading when they said that. I guess I should have just stuck to my guns on the long term.
I would say number 6. I expected you to say yes and no. Okay.
Okay, cool. All right.
So here I'm telling you what I think. I would say no, his cancer is not curable, but I can see why you would think he would really benefit from this treatment, because he will, but he's not going to be cured by it. Okay.
Right.
So he might, and that's why the long-term survival thing is a little up for interpretation. So depending on how you interpreted long-term survival, I will look at your answer and with regard to that. Okay. And I understand some of you will say yes, some will say no. They're both right. Depends on how you look at it. I'm just telling you, though, an oncologist would say no. Okay. So.
Okay.
Professor,
Yes.
I have a question. So if he stays on this drug for a long time, probably if he survives more than 5 years, does that mean that he is, I don't know, his cancerous is stable?
Well, that's a good question. It probably wouldn't happen. And the reason is that most patients will progress within 5 years of starting this drug. I think almost all of them do. So there aren't that many patients that are going to be 5 years later still taking this drug and showing stable disease. You know? And it's just because the tumors keep mutating, unfortunately.
Oh, okay, yeah, that's the question.
Yeah, so it's no longer just the fusion, it's like other things happen too.
All right. Thank you.
Mm-hmm.
I have a question related to standard treatment. So before you said that if the disease is, has distant metastases, then the surgical oncologist wouldn't like try to take out the tumor. So I've heard like in cases of like prostate cancer, the first thing that they do is surgically remove, and then if there's distance metastases, then they'd use radiation. Is that specific to prostate cancer?
No, and we'll see when we get to the prostate cancer lectures in the unit on that, that typically localized disease is what is surgically resected, or we'll get radiation treatment. But typically also with prostate cancer, once it's metastatic, meaning they see it in other organs, it can be metastatic to regional lymph nodes and they'll still take out the prostate and the lymph nodes, okay? So surgery will still be done. But if the cancer is already in the bones or in the lung or the liver, there's no surgical resection. And the reason is that you're putting a patient through an unnecessary procedure. You know, it's not curative. It's a metastatic disease that kills people. It's not the primary tumor. You know, once the horse is out of the barn, okay, subjecting the patient to a fairly substantial surgery is not beneficial.
Okay, thank you.
Mm-hmm. Okay, all right. So are there any more questions on the worksheet? Because we should move on to discussing colorectal cancer. Yep, Charles?
Quick one. So lesions are a broad term. I mean, right, like they describe it, or at least I saw a definition that said it's any malformation of tissue. Is there a way to kind of see with the response to chemotherapy, right, in this case, can that determine whether that lesion is malignant or not just based upon its response? Or could it also be that it's just going down on its own and it's not a direct product of combination chemotherapy?
So tumors will not go away on their own, unfortunately. Right. So, but you do look, and we'll see. They didn't do it so much for this particular case, but in other cases, you'll see that you do sequential imaging to make sure to see whether or not the chemotherapy is having an effect. So if you go back and look at when we were talking about assessing whether chemotherapy was being effective in breast cancer, and we showed that PET CT scan of a little breast tumor, little metastatic focus that was either responsive to the chemo or not, okay? So that kind of imaging has to be done over time to see if the patient is still responding to. Okay, hold on one second. Here we are. Let's do that. And I'm going to pick this, and we're going to share. And I'm going to, let's see here. Okay.